Prostate imaging, an update from our best friends at Mayfair Diagnostics. Shelley Spaner has been here before and always enlightens us with some great information. So she's going to be reviewing the prostate cancer diagnosis. She'll have some discussion on the expanded role of the MRI. And then Brendan will talk to us about the new 3 Tesla MRI at the Rockyview Hospital. So I'm excited to hear about that because we read about all this new technology. So we're going to get it firsthand from Brendan Diederichs. And then Grace Yeung is going to talk to us about targeted biopsy program at the Rockyview. So this again is new evolving technology, and a lot of us will have heard little bits and pieces about it. Now we're going to get the full story from Grace, so we're excited for that.
Thank you so much again for having me again, the third time I've been here. So I didn't want to bore you with just me, so I've brought 2 of the brightest young stars that we have at Mayfair Diagnostics who are going to add a whole bunch that I can't add. But when I first came here, which I think was about 4 years ago, we were just starting to talk about prostate MR and how we could, that's our outline, how we could use imaging to help in the diagnosis and even the treatment of prostate cancer. And it's amazing to me that in that 4 years or so since that time, things have evolved to where we are now. So I'm going to spend my 20 minutes or so just talking initially about the diagnosis of prostate cancer, and then I'm going to just spend a few minutes talking about how things have evolved. And to do that, I'm going to review the recent literature that we have. So all of you in this room know that prostate cancer is very, very common. It's the 3rd most common diagnosed cancer in Canadian men. 3rd leading cause of cancer death, behind lung and colorectal cancer. And the rate of newly diagnosed cancers, it initially increased by about 1.1% per year between 1996 and 2008. But what was interesting is that after that, there was a decrease in the diagnosis of prostate cancer. And if you talk to anyone at the Prostate Cancer Center, the reason behind that is PSA screening. I'm going to touch on the controversies of PSA screening, but that's a statistics that's a statistics that is hard to deny. There has to be a reason for that. The only way currently to diagnose or to find out about prostate cancer is with PSA screening. So I use that statistic to support the early screening of prostate cancer. The other thing that's interesting about the statistics is the rate of death from prostate cancer has actually decreased between 1996 and 2012 by about 2.9% per year. So from 1996 to 2012, the median age of diagnosis decreased from 71 to 67. The only reason for that has to be screening, and the only screening that's done is PSA testing and digital rectal exam. So I think that's pretty powerful as well. And the median age of death from prostate cancer increased from 78 to 82. So again, the only reason for that one can find is screening, and the only screening is PSA screening. So obviously I'm a strong proponent of that, and until we find something better, which we may, and we hopefully will, that's where we're at. So currently we diagnose prostate cancer by an elevated PSA and or an abnormal digital rectal examination. We're super lucky in Calgary and in southern Alberta because the minute you have an elevated PSA after age of 40, you initially get referred to the Prostate Cancer Center, and within 11 days, that's the mean, you'll see a urologist. The urologist will see you at the Rapid Access Clinic and will give you the option to undergo a definitive or the current definitive diagnosis for prostate cancer, which is a transrectal biopsy. So currently we use a 5 to 7.5 megahertz rectal probe, and we take a series of 12 biopsies, and using those biopsies we diagnose prostate cancer, and we diagnose the grade and the stage, and we've all talked about that before, and we know about that, but that's how we diagnose prostate cancer. We also have talked about the huge limitations of that technique, and as a woman, it's really easy for me to sit here and say, that's a horrible way to diagnose any cancer. If I was a man, and I'm not, I'm a woman, but if I was a woman and I was told I had a breast cancer, and I was just going to take a series of random core biopsies from my breast, I wouldn't do it. There would be no way I would do it. And so it still is a bit hard to believe that this is still the standard of care, but it is. And the limitations of it are significant. So cancer's missed in, up to a third of cases, up to 38% of cases. The places that the cancer is missed is where the probe can't get to. So the far portions of the prostate gland, so the apex and the lateral and anterior cancers are the ones that are most commonly missed. And we only extract less than 1% of the gland tissue, so you're not sampling 99% of the gland. And I've talked about this before, but prostate cancer is a very multifocal, heterogeneous cancer. So there can be little bits that are low grade and little bits that are high grade. And if you only sample 1%, your chances of overdiagnosing or underdiagnosing are huge. And that's the hugest limitation, is you underestimate the grade and stage in up to 46%, which is pretty close to half of the cases, and you overestimate the grade and stage. And so you're left with almost a crapshoot. And that is still the way we do things. That's still the standard of care. And so obviously there needs to be a better way. I'm going to talk to you about that in a minute, but I just want to make sure we all know where we're at. So when we make the diagnosis, and I just bring your attention to this, because when I first came to talk to you, we were using the guidelines from Alberta Health Services guidelines from 2013. Those keep getting upgraded each year. There was a large time when there wasn't any change in what they do in Alberta Health Services to diagnose and stage prostate cancer, but these are changing year by year, and it's because of the work that's being done in prostate imaging, so it's pretty exciting. So once you've made the diagnosis with that random core biopsy, we want to assess you to whether you're going to stay with active surveillance and just watch this and see what happens, or if you're going to treat it, and you're going to treat it for cure. So of course you see the urologist, they do a history and physical exam, they do routine blood work, and then they start to image, and we've talked about these before. So we use nuclear medicine bone scan imaging in patients with high risk disease, so Gleason 7, 8, or 9, you'll have a nuclear medicine bone scan. And in patients with, again, a high-grade disease, Gleason 7, 8, or 9, you'll undergo CT scanning. And that's only to look for lymph nodes and to look for metastatic disease. It's not to evaluate the prostate gland at all. So in 2017 and 2018, there were changes made to Alberta Health Services, and these include the ability for the urologist to use MRI as one of their tools. Not currently accepted for staging routinely, but definitely becoming more acceptable. But one of our friends here was talking about being on active surveillance, and this is in Alberta Health Services guidelines now, that MR can be considered for patients who are undergoing active surveillance if their PSA is rising or their digital rectal examination changes. The first step is MR. And that's a huge difference from when I was here both other times. That was not in the realm of the Alberta Health Services guidelines for two reasons. For number one, there was no literature proving this or supporting it, so it wasn't acceptable. And secondly, the cost, which is still one of the guidelines that we in Alberta and in Canada we have to worry about. I'm going to talk about controversies in screening because it's so relevant and it's so prevalent, and when you're in the middle of it, as any man is, you don't know what to believe. And the controversies in screening, if you're a woman, the changes in breast cancer screening are almost monthly or yearly. There'll be a new task force that comes out and says, don't screen after 40, don't screen after 50, all these different things. So at the Prostate Cancer Center, we're very, very strongly supportive of PSA screening at age 40. You can argue it either way, but I'm going to try and prove it to you that there's no better way at this point in time, and probably for at least a decade or so. So my proof is that there's been a 44% reduction in prostate cancer over the last 20 years. So any paper that you read, about 45 to 70% say that's attributed to PSA screening. That's not a whole lot better than random core biopsies, but it's a little bit better. But my question would be to those 55 to 30% that say it's not attributable to PSA screening, what else is it attributable to? Because there's no other way, apart from digital rectal exam, to screen. So that's one of our arguments at the Prostate Cancer Center. The United States Preventative Services Task Force in 2012 recommended against PSA screening because overdiagnosis and overtreatment of cancers that are not going to do anything. They changed their tune in 2018 and recommend screening, PSA screening for men over age 55, from 55 to 75. On either extreme, they don't recommend any longer, so those guidelines have changed. The American Urological Association, the AUA, and the Canadian Urological Association both suggest screening at age 40, and that's what we're doing. The PIVOT trial is one of the most robust trials that has ever been done in prostate cancer, and it was a prostate intervention. So they either took out the prostate gland with a radical prostatectomy or they observed the patient under active surveillance. And they took 7,000 patients and followed them for 10 years and did not come up with a recommendation, apart from saying that they weren't sure either way. As late as 2017, so that's just literally 2 years ago from where we are now, the New England Journal of Medicine, which is truly the Bible of medical journals, it's read by everybody that reads medical journals, said there was no real hope. And it's really interesting because things changed so quickly. So 2017, they basically said there's still no clarity about the usefulness and the desirability of a routine PSA screening after 25 years. Two large trials, which were the PIVOT trial and the other ones suggest, I'll get back to it, suggest that there's no benefit. And so under the first do no harm of being a doctor, it seems reasonable to forgo mass screening. So this was just in March of 2017. And to continue to look for any other way that we can look for prostate cancer. There's a critical need for strategies to reduce the burden associated with the diagnosis of indolent disease, so to diagnose things that aren't going to kill you through a combination of not diagnosing it in the first place or actively classifying it. And that's the most pressing research challenge going forward. And that's just 2 years ago. That's March of 2017. So things started to get really interesting in diagnostic imaging because we thought, and what I talked to you about last time was, well, maybe imaging is the way to go. If blood work isn't going to be the way to go, maybe it is imaging. And the future of prostate imaging is a few things. High resolution ultrasound we're still working on. Dr. Heinemann is doing a couple of trials on high resolution ultrasound and contrast enhanced ultrasound at the Prostate Cancer Center and has some promising results. It's a little bit more tricky than MR in that it's operative dependent. So the images change with the person who's using the ultrasound, whereas MR is not operative dependent. So I think that's one reason why multiparametric MRI, which is what we're going to spend the rest of the talk discussing, is becoming more relevant. And then molecular imaging, that's in our horizon. There's a chance that there'll be a PET scanner that comes to Calgary in the next 5 to 7 years, and that will change things again. But we're not quite there. I think I might have shown you this slide before, my favorite of all slides, because the National Health Society in Britain actually approved this trial and hasn't helped much, but it was cute. Anyway, the emerging role of MR. So MR is not brand new. It was first introduced in the 1980s, but when it was first introduced in the 80s and 90s and early 2000s, it wasn't very helpful at all. If you did an MR of the prostate gland and showed it to 10 or 15 different specialists, urologists or radiologists, you'd get 10 or 15 different diagnoses. So it didn't gain any favor at all. But with this still very limited ability to diagnose prostate cancer that's aggressive and that's going to hurt people, there was a need to find the ideal test, and it had to be minimally invasive, have to have few side effects, if any side effects. It would identify the men who would benefit from the treatment, and it would de-identify or not identify men that had insignificant cancers that they aren't going to die from. They're going to die from something else. And so that's where things got really exciting. And this was also in the New England Journal of Medicine, literally 1 year to the day after they said, we are left with nothing. And this precision trial has basically changed everything. And what it's done, I'll just explain the trial quickly, but it took about 500 patients and it randomized them into 2 different arms. So these were all patients that had the same characteristics. So they had either an elevated PSA or an abnormal digital rectal exam. They'd never had a prostate biopsy before. And they randomized them into two arms. Half of them went on to that standard 12-core transrectal ultrasound biopsy, and the other arm of the trial, the other half of the men, went on to have MR. If on the MR they had no lesion that looked like cancer, they didn't have a biopsy. If they had a lesion that looked like cancer, and that's what I talked to you about before, and Brendan's going to spend a bit of time on what the cancer looks like, they had a biopsy, but the biopsy targeted the area that looked like cancer. And the overall findings from that trial was that those men that were treated with the MR-guided biopsy or not biopsy did better. So fewer men underwent a biopsy, more clinically significant cancers were identified, less over-detection of clinically insignificant cancers, fewer cores. So one of the reasons that you get post-biopsy complications is that you have to take more samples. So fewer cores that were needed to be obtained, and the side effect profile post-biopsy was better. So everything about it was better. I'm going to move a little bit quickly through here just because I don't want to take all your time, but they detected the clinically significant cancer in 38% of the targeted group as opposed to 26% in the standard biopsy group. Fewer of the men were diagnosed with a clinically insignificant cancer, and more of the cores were positive. So the key strengths were this trial can be randomized across any center. So it doesn't have to be an academic center in the United States or Europe. It can be any center, including Rockyview or any place in Alberta. The standardization for imaging was also widespread. So just like the PIRADS technical limitations, it didn't matter what your magnet strength was. It didn't matter if you used an endorectal coil or if you just used a body coil. And all of the different ways to do the biopsies were included. So they thought they could have done better if you would have narrowed those standards, but they also want this trial to be able to be utilized throughout all centers. So that was very interesting. The limitations, they're still worried that if you don't biopsy a man who has a negative MR, that you might miss a cancer. And so what they've decided is they'll follow those men. And I think that's what we've also decided, and that's what active surveillance is. I'm not going to go through the limitations, but in conclusion, men with clinical suspicion of prostate cancer, the diagnostic pathway of including MR before biopsy and then targeting the cancer suggests that this type of diagnostic pathway is better than what we're currently doing. And that's really great, because what that implies is that we're redefining the cancer diagnostic pathway. We're reducing the number of patients that are undergoing prostate biopsy, and by doing so decreasing the risk of biopsy. We're reducing the number of cores, and by doing that, reducing the risk, reducing the related sepsis, pain, and other side effects that you can have. And we're hopefully reducing the overdiagnosis of clinically insignificant cancers, and by doing that, decreasing the economic burden of diagnosing and treating prostate cancer. So that paper was introduced in March of last year, March of 2018, and from that came hundreds of papers afterwards, almost every single one supporting it. And it's interesting because I pulled up PubMed through the years, and I hope you can see that. These are just searching prostate MR. Can you see that? I don't know if you can, but PubMed is basically the library of all medical journals, and you can search by anything. So I chose to just search by prostate MR. And you can see back in 1982, 1983, 1984, there's a few papers a year. That red arrow tells you when the precision trial was introduced. And after that trial was introduced, the number of papers just skyrocketed. So between 2012 and 2018, the amount of literature tripled. And already in 2019, there's 307 articles in PubMed about this technique. It's really hard to stay up to the literature. It's hard to stay up to date. But I think you can tell by that is that this is really one of the most exciting things that has ever happened to prostate cancer diagnosis, and as well, prostate cancer treatment and active surveillance. I just pulled, this is just from February of this year, and the Genitourinary Cancer Symposium in the States is one of the biggest meetings that there is. And this fellow that from New York University, he's a urologist, and the urologists were a little bit slow to buy into this diagnostic imaging. And I just thought this is just exactly what we're hoping for. We've got the urologists buying in, we're doing a better job for our patients, and just this one thing, greater than 95% of the patients at New York University now get an MR during their prostate cancer evaluation. So I think that's where we're headed, and I'm going to stop there and give it to Brendan, who's going to show you what we're doing at the... I want to introduce Brendan because he didn't get a very good introduction, and then I'm also going to introduce Grace as well, because Brendan did his training in Boston at one of the best universities in the States, and has amazing training on top of being an incredibly intelligent person. So we're incredibly lucky to have him in our group. And what's brilliant about him coming here is he's brought really the up-to-date knowledge and brought it to us, and he makes the most difficult concepts seem so easy. So I'm lucky that I get to work with him, and you guys are super lucky that you get to listen to him right now. So this is Brendan Diederichs, and he is probably going to be the next best radiologist in our realm.
Yeah, don't set the bar too high, Shelley. Okay, so my name's Brendan Diederichs. I'm going to talk to you a little bit about what we're working on, specifically at the Rockyview General Hospital in the realm of prostate MR. Let me see if we can get this going here. Okay, so as Shelley said, I'm one of the radiologists. So I'm one of the doctors that both looks at imaging, diagnoses things on imaging, and I also do some procedural work as well. I did medical school in Edmonton, did residency training here, partly under Dr. Spaner, and then went down to the Massachusetts General Hospital and did some fellowship training before coming back here just under 2 years ago. And the training was geared, basically my specialty is everything between your diaphragm and your pelvis. That's kind of where I live my professional life. And part of my training was also specifically in prostate imaging. In the program there we did about 50 to 100 cases per month, or patients per month. So just to update you about what we're working on in the Rockyview General Hospital. So I'm fortunate in the sense that I came back to join Shelley's group and work at the Rockyview General Hospital at a time when it was time to replace the MRI system. And so I was asked actually to participate in the proposal to AHS for what we're going to do to replace the system at the hospital. And so normally what we do in imaging is we learn about our machines and we do everything we can to extract the best quality imaging, the best quality tests out of the hardware that we've got. And it's pretty rare, in this case I think it was 10 or 15 years, when we actually get the opportunity to improve that hardware. So I jumped on that. So we put together a proposal to replace the 1.5 Tesla system, and the Tesla is how strong the magnetic field is that you're working with an MRI, and it's one of the fundamental parameters that underpins what the quality of your imaging is. It's not the only one, but it's one of the big ones. So we pushed hard to replace it with a 3 Tesla system, mainly because the Rockyview General Hospital is the diagnostic imaging support for the Southern Alberta Centre of Excellence for Urology. And one of the other goals that we had was to expand the capability or the regional capacity for imaging research on 3 Tesla systems, not just in urology, but also in the broader realm of body imaging and other areas of imaging that benefit from high field strength, so musculoskeletal imaging and ophthalmology specifically. So this is what we do in radiology. We've got machines on the top. We take data from those machines. We tell them how to extract data from patients without touching them, in most cases without touching them. We build images off of that, and then us radiologists live in this corner and look at those images, come up with diagnoses. We put out information in reports to the referring physicians. And then the other part of our responsibility, the other part of our jobs is to analyze that data to see how good we're doing. And there should sort of be an arrow from the bottom to the top to inform what we're doing on the image or on the acquisition side of things. So this is what I'm going to talk briefly about, or hopefully briefly about. So how does MR work? Very briefly. So MR does not use radiation. It's very different from our other imaging technologies. So CT and X-ray, for example, or CAT scan, use X-ray beams to shoot through patients and see how dense things are. But MR is completely different. What we do is we put patients into a big magnetic field, which is pointed in one direction. And when we put you in a magnetic field, all of your protons, of which you're made up of millions, line up in a particular direction. And then we tell the machine to do a sequence of radio frequency pulses, as well as magnetic gradients, and it flips those protons in all sorts of different directions relative to that same magnetic field. And then we listen. And those protons relax back to the same direction, and they actually emit signal. And if you listen really hard because you've got fancy equipment, you can actually generate images out of that signal that's brought back from your tissue. So we boil down the types of imaging that we do. There's a lot of words on some of these slides, but I'm just going to sort of talk through the jargon into different tissue weightings, so T1 imaging and T2 imaging. And those show us different pieces of the tissue. So more fluid weighted sequences, we can look at cellular density in cancer, which is what we do in prostate cancer. But in reality, the images that we create are infinitely variable because there's so many different ways that you can flip those millions of protons. And so the complexity in MRI imaging is at least an order of magnitude higher than CAT scan and X-ray, which is what makes it such an interesting field to work in. So prostate MR currently in the region, these are sort of the big 3 indications, the big 3 reasons why urologists will ask us to do a prostate MR on a particular patient. The first, and that it's changing, and the number in each category is changing, and this I wouldn't say is necessarily comprehensive, but these I would say are the big 3 currently. So the first is a patient with high PSA or a high clinical suspicion on the basis or on the part of the urologist for significant cancer, but a negative systematic biopsy, the original biopsy that Shelley was talking about. So the concern is, are we missing a treatable malignancy? The next category would be someone who has a known high-risk cancer based on that standard biopsy, but the surgeons want to know where it is and whether or not it's extending outside of the gland. So they want us to do local anatomic staging. They want to know, is it extending outside of the gland, and is it involving those neurovascular bundles on the side of the gland? Because that guides them in terms of the type of surgery that they can perform, whether or not they can spare those neurovascular bundles or whether or not they have to take them with the gland because they're involved by cancer. And the last is a growing category in the region, which is patients who have a known low-risk cancer and are on active surveillance. So we're starting to monitor more and more patients with longitudinal repeat MRs to try to pick out the patients that need repeat biopsy because they might be converting into a higher risk cancer. So I'm going to talk briefly about the different types of those sequences, the flavors of imaging that we generate with an MR machine. So T2 is one of the 3 core sequences in a multiparametric prostate MR, and this gives us overall anatomic detail of what we're looking at. It helps us with tumor localization as well. So this is an image that shows we're just above the level of the prostate gland, as if you're cutting through a patient like a slice of bread. And this is showing the detail of the seminal vesicles, which we want to evaluate as to whether or not they're involved with prostate cancer. Just behind those is the gas-filled rectum, and this is a partially collapsed bladder. And now we've moved down into the prostate gland itself. So you can see the partially collapsed bladder on top of it. And then we see the zonal anatomy of the prostate gland, and we see its edges quite well. The peripheral zone is this bright area around the edge, and the central zone and transitional zone are in the middle. And the majority of prostate cancers arise in this peripheral zone around the edges. So we use this brand or flavor of MR sequence for tumor localization. So you can see this area is near the apex or the bottom part of the prostate. This is all peripheral zone. And these, you'll have to trust me when I tell you, these dark spots are all small foci of prostate adenocarcinoma. We know exactly where they are, and they're extremely tiny. So you can kind of get an idea as to the systematic biopsy that Shelley was talking about. These tiny foci of cancer, you would expect would be relatively challenging to get with precision using a systematic or blind quote-unquote technique. We also use it to not just for tumor localization, but in the center of the prostate gland, which grows with benign prostatic hyperplasia. It's the primary sequence that we use to know or to determine whether or not something itself is a malignancy. We get all these BPH nodules, which are benign, and the T2 sequence, based on what we know and what's been published, helps us to determine what's malignant and what's not. And then finally, this is the core sequence that we use to look at the edges of tumors. So this is an example of what a tumor would look like extending outside the edge of the prostate gland. This dark tissue, as opposed to the light normal appearing peripheral zone on the other side, is extending outside of the prostate gland and involving neurovascular bundles. So we tell the surgeons, this is where the tumor is, it's involving the neurovascular bundle. If you're going to save a neurovascular bundle, it's got to be on the other side. The other sequence, or the next sequence, one of three that we use, is called DWI, which is Diffusion Weighted Imaging. So it's a roundabout way of looking at how dense, cellular-wise, tissue is. So cancers grow rapidly, and they have very high cellular density. So fortunately, we've developed a sequence, or a sequence has been developed, not us, over time, which has been able to basically show bright signal where there's high density of cells, i.e. cancer tissue. So everything that's bright, although this sequence doesn't provide the same anatomic detail as we see the T2 does, it maps out very nicely for us exactly where the highest grade cancer is, or adenocarcinoma is. And the last sequence that we use is called dynamic contrast enhancement. So there's a common theme both in names of procedures and names of medical imaging, and that's that medicine likes to attach fancy names to relatively simple things. So this is just a blood flow map. And everything that's bright on this map is where we've injected contrast into the vein in a patient's arm, and we've watched where that blood flow goes. So normally in a patient that has BPH, which is pretty much every man over the age of 50, there's a lot of blood flow and contrast uptake in that transitional zone in the middle of the prostate gland, and here at the edge of the prostate gland is some enhancement where it shouldn't be, and that's a Gleason 7 prostate cancer. So I'm going to glaze over some of this, but PIRADS is our standardized scoring system. And we have this in a number of areas of the body for malignancy grading or imaging reporting that gives us a common language to talk to clinicians about, other doctors about, to confer what the likelihood is that we think something is malignant and something needs to be done about it. So it also tells us actually how to acquire these images, how to sort through the complexity of MR imaging. It gives us a baseline minimum standard to work with, but it doesn't tell us what's best. Because at the time that this was published in 2015, things are still evolving quite rapidly. So this is a paper, these probably they don't seem to project very well, but the point of this paper was actually to show that if you use those minimum parameters in that guideline, you can actually end up with vastly different imaging. So although it doesn't seem to be projecting quite well, the point of this paper is that in this particular prostate gland, you can see the edges of the prostate gland perfectly, whereas in others, you can't see it at all, and you sort of infer where the edge of the prostate gland is. But that's not good enough, because if I'm trying to tell a surgeon where a tumor is, and if it's extending outside of the prostate, if I'm guessing where the edge of the prostate gland is, that's not quite good enough. So the point of this paper is to show that PIRADS, adhering to the minimum PIRADS guidelines, isn't good enough to ensure best imaging quality in an acceptable amount of time. So, very jargony. There's going to be a lot of words on these slides, but what I want to impress to you is that these top 3 things are the 3 things that we are able to improve and change with the new system. And these are the big 3 in terms of MR imaging quality. So field strength is the one that everyone talks about. The strength of that background magnetic field, 1.5 versus 3 Tesla. Gradient specifications I'm going to talk a little bit about, but not too much about, and that's basically the horsepower that's in your engine. And the receiver coils are something that's placed on top of your body when you're in an MR magnet. It's a soft, flexible piece of padded machinery, which is our eyes or ears. So its job is to listen to that signal that's emitted back from the patient. And it also is fundamentally important in terms of the imaging quality that we get. Now, all of these words are intentionally small. So all of these categories on the bottom, this is all the knobs that we mess with as radiologists, and they're all intertwined. So what we do is we fight with them and we change them and we alter them, and they're interconnected, but they're all under these core features of hardware that we only get an opportunity to change once every 10 or 15 years. And then in the other corner this is what we're looking for. We're trying to squeeze out of our images. Either high signal to noise ratio, spatial resolution, these are all metrics of imaging quality. And they're all trade-offs. The underlining feature or underlining framework that we have to work in is we have to do it in an acceptable amount of time, because we need to keep wait lists low and we need to get to the next patient as well, and we need to do a good job for everybody. So with regards to field strength, this is generally accepted. You're allowed to perform, according to PIRADS, prostate imaging at either 1.5 or 3 Teslas, but generally everyone is now moving towards the agreement that 3 Tesla is the way to go. Why is that? So this is my analogy. So on the left is my Volkswagen, and on the right is someone's Audi. And so these 2 brands of vehicles won't necessarily tell you how fast you're driving, but they generally will communicate to most people what you're capable of doing, which I think is a reasonable analogy. So what we've gone with is the Siemens 3T Vita system. So it's the newest 3T magnet available from Siemens, which is, I would contend, the highest quality imaging manufacturer specifically for body imaging. And this is their top of the line system for dedicated clinical imaging. These are a couple of images of the suite in the Rockyview General Hospital being updated, because putting a new system in, the shielding for the whole suite actually had to be updated because it needs to have a higher degree of radio frequency and magnetic shielding to be able to put a system like that in. And that's both to ensure high quality imaging, but also just to protect patients that are going by in the hallway, because strong radio frequency pulses, you don't feel them at all, but if you happen to have a non-conditional or a non-compatible pacemaker and you're going by in the hallway, it can reset that. And I was really excited when I went in to see how this was working, because I thought it would be very high tech, but actually it's incredibly low tech. All it is a bunch of copper sheets lining the entire room. So you can see the shine of the copper and the edge of their wrapped around pieces of wood, and then there's basically pieces of paper put over top of them, and that's it. This is the crane bringing in the system, and this is this past fall when the system came off of the truck, and I was so excited. This is the finished control room where the technologist sits and monitors the exam, and also monitors contrast injection. And then this is the system finally installed. So the other 2 hardware components of the big 3 are those gradient specifications. So if I was to continue with that same analogy, I don't know much about cars, but just assuming that the one on the right drives a lot faster or has more horsepower than the one on the left, although they're both, say, 3T or Audi. And so gradient specifications are often overlooked, but incredibly important. And that's, in addition to the static magnetic field, how quickly you can ramp up changes in that magnetic field, because we do that all the time in MR imaging. And so there's 2 fundamental measurements of how good a system is. And that's the peak strength and the slew rate. So how high you can ramp up your magnetic field or gradients, and how fast you can do it. So we pushed very hard to have XT gradients on this system, specifically because prostate imaging is very demanding. And this, I was somewhat surprised, but we were able to get it at substantial cost. I'm proud to say that this is the first, and as to date, according to Siemens, the only VITA system that's been installed in Canada with these upgraded gradient specifications. So by comparison, a 3T system that we have at the South Health campus and a GE that functions in the community with comparatively lower, substantially lower peak gradient strengths. Usually the downside of having this piece of technology is having higher gradient strength makes your bore, the middle of your magnet, smaller, which gives us trouble because it limits the size of the patients that we can scan, and it also causes problems with claustrophobia as well. But I was surprised when we were speccing this system that in spite of the upgraded gradient specifications, we maintain a bore size that's equal to the largest systems that we have in the region. And those receiver coils, so briefly I'll talk about those. So we made a little bit of an unconventional choice in terms of what our listening device is going to be. And rather than going with the conventional body coil, which emphasizes covering a large space on the patient, we actually went with an orthopedic coil because those coils emphasize imaging high resolution fine detail and pieces of cartilage or bony trabecula, and that's actually what we're looking for in prostate cancer imaging. So what are we looking to maximize? Basically spatial resolution with T2 imaging. So with these improvements, you can see an example of what we're able to achieve on the left. I hope that translates. And then these are 3T scans actually on other systems in the region. And if I ask you to be a radiologist for a moment and ask you which edge of which prostate gland you can see best, I think that's pretty straightforward. With the new system, we can basically see things more or less perfectly in the absence of artifacts, whereas previously we were making educated guesses. Again, looking at the transitional zone, this is what we're using to determine whether or not there's cancer in the transitional zone, and what we use. The decision-making tree is somewhat complex, but basically what we're looking for are these lines that are encapsulating BPH nodules, as well as little bright spots within benign stromal hyperplasia, and they're a lot easier to see. This is an example of exactly that. So on the left, you can see a perfectly encapsulated nodule, which I know with 100% certainty is benign because that capsule is there, whereas previously it's invisible on the exact same slice. Same thing here, a stromal BPH nodule, and I can tell you that it's a stromal BPH nodule and not cancer because of the line that I can draw around it, and by virtue of the fact that I can now see that. And again, another example, the difference here perhaps is a little bit more subtle, but when I'm looking at the edge of the prostate gland, I know where it is with certainty, down to about 0.4 millimeter resolution, whereas previously I can make an educated guess as to where it is, but it is an educated guess and not direct visualization. With regards to that diffusion-weighted imaging, we've done a number of things with this new hardware to improve things. So currently we're performing, or the previous regional standard was to perform diffusion-weighted imaging with something called a B value of 1400. And that B value is basically how diffusion-weighted, how cancer-weighted that sequence is. And you can't just crank that knob up, because when you crank that knob up, the artifacts also increase. And I'll show you some of that artifact. So this is what happens when you jack the B value knob up at 3 Tesla. You lose portions of the peripheral zone in your visualization and assessment because of that artifact. Again, the same thing here. This person's prostate gland extends back here, but we're losing a chunk of tissue because of artifact at 3T because of a key hardware limitation. And again, an example here, where we're losing imaging in the posterior aspect of the prostate gland, whereas when we can get rid of that rectal gas, we know that there's actually a lesion here, which in this case is PIRADS 4. So this is the issue that I'm hoping to highlight with the previous DWI sequences, that we're missing pieces of tissue bitten out of the back of the prostate gland, whereas we know the peripheral zone goes all the way back here. Another example, missing tissue back here and just missing information in an area that's critical to assess because it's the peripheral zone where most prostate cancers arise. And a final example here, again, missing tissue in the back of the peripheral zone. So what we've done with the new system is we have considered this at all steps. So building the sequences, acquiring the hardware, and speccing the new system. And on the bottom, we can see that we've got rectal gas, and we should be having that same artifact, but for the new hardware and the new sequence, where there is increased SNR and basically no susceptibility artifact, none of that artifact that's limiting our interpretation of about 1/3 of the gland. And again, you can see the difference between the two, the new on the left. This person's prostate gland did not change shape, but we're simply being able to see the back of the gland. And the last thing that I'll talk about is just how diffusion weighted we can go. So I mentioned that B value of 1400. This is a DWI sequence where we're sequentially increasing that cancer weighting. You can see how conspicuous that bright spot in the peripheral zone is getting. Right now, our sequences are sitting between these two at a B value of 1400, and it requires a lot of windowing and post-changing of the images to try to guess where that cancer is. So if we can get our hardware to a point where we can actually turn the B value up, it's easier for us to see those cancers. And so we've been able to get up to a B value of 2000, and you can see how much brighter those spots of cancer get compared between 1400 and 2000. This being the anatomical T2 sequence to see the spot of cancer and its location. Again, same thing here, these tiny spots of malignancy and how much brighter they stand out against a background of normal tissue at a B value of 2000. And the last thing, contrast enhancement, so blood flow. So this is a sequence that requires high temporal resolution. So if you only take a picture as someone's running by every 5 seconds, you don't really get good detail in terms of how their leg is moving. You might see me on the ground like this, you might see me flying in the air, but you don't really have a good detail. You certainly wouldn't want to watch a movie which was just a picture in time every, say, 20 seconds. So PIRADS demands a temporal resolution of 10 seconds or less, preferably even 7 seconds or less. But there's a trade-off in that. And if you just jack up the temporal resolution, the quality of your image gets blurrier and blurrier and blurrier. So there's a new sequence that's available with this new scanner, which we've optioned, which was actually designed for liver imaging. And it was designed to be able to reduce motion artifacts so that patients didn't have to hold their breath. But what we found is that you can actually turn that sequence on its head and use it for a purpose that it wasn't designed. And you can jack up that temporal resolution knob and still have very high quality imaging. We're using it for a completely different purpose than it was originally designed, but we've discovered that it works quite well. And so now we can basically take a prostate gland and scroll through it in space, or we can scroll forward and backward in time. So you can see how things are lighting up and going back and going forth. And here in the back of the peripheral zone, I can wind back time until I find the earliest enhancement of the small focus of cancer. And so that's basically where we're at with prostate imaging at the Rockyview General Hospital. It's an exciting area for sure in the area of diagnostic imaging because it's so rapidly evolving. And also I feel very fortunate to be able to have been involved in sort of the new system, which is now up and running as of the past month. So thanks for your time.
So it's a technical area, but I think Brendan did a really good job of breaking it down and making it a bit easier to understand. The final part of where we're at right now is that targeted biopsy, and Grace Yeung is one of the interventional radiologists that works at the... Do you have a question?
Yeah, could I just ask further to that, in the gentleman that's had a prostatectomy, can you see this being used to detect anything that's left, say for radiation purposes, or to be able to direct it more accurately?
Yeah, so I didn't include that on the list, but it is a growing indication, and we are being asked by the radiation oncologist to do that. So sort of two areas. One is looking for recurrence in a previously radiated gland. And what we're finding the radiation oncologists are asking us to do is we're doing more and more baseline imaging after radiation therapy, for example, to know at a baseline stage what the prostate looks like, so that at a future date, if the PSA starts rising, we can compare it back to that baseline we had. And then the other growing indication, but is still relatively few cases in this region, is post-surgical recurrence, where there's an early rise in PSA. We are doing still relatively few cases, but it is feasible, and we are doing more.
And actually that's a great question as well, because in post-prostatectomy patients with rising PSA, sometimes you're not sure, and sometimes that's also an indication for biopsy, which is what Grace is going to talk about. And I'm going to mess it up because I never asked you, but Grace joined us about 7 years ago? 7 years ago, and she did her training, her fellowship training in interventional in Vancouver, and she's been just an absolute blessing for our group, because she has taken over all of the biopsies that we do and has made sure that we're doing them correctly. So she audits the work that's done by the group of radiologists that do the biopsies, and make sure that our work is on target with what is being done across all of the academic centers. And that's incredibly important and hard work, and she's been able to do that. She's going to spend just a bit of time talking about that and the work that she does. She's also lovely and so much fun to work with. So.
Thank you, Shelley. Thank you for inviting me to come speak. Very hard acts to follow, landmark trials, landmark technology and MRI, but bear with me, 15, 20 minutes, and we'll get you to checking the flames results. So I'm going to talk about prostate biopsy in general, and a little bit about our program. Make sure I know how to forward this slide. Okay. So just a little table of contents. I'll just talk about some historic background and relevance of why we care about biopsy, because no one looks forward to seeing me, and we want to get rid of biopsy in general as much as we can. Just about the transrectal ultrasound guided biopsy itself. I'm sure some of you have experienced it personally, so this will be a revisiting of that. Our MRI targeted biopsy program and prospects, and just a very quick touch on the targeted biopsy program at the Rockyview General. Okay, so in any talk, your time is important. Why should we care? So this alludes to a bit of what Shelley has discussed. So this is all about prostate cancer screening and prostate cancer detection. Prior to the advent of PSA, as Shelley had mentioned, prostate cancer would be detected and it would be too late. It'd be incurable. But since the advent of PSA, there is an increased rate of cancer detection. And in fact, 5-year survival is nearing 100%, which is incredible if you think about the difference it makes in someone with that diagnosis. However, the role of cancer-related mortality reduction has been debated, again, as Shelley has alluded to, and you know the guidelines have gone back and forth on when you should do it, how often you should do it, how you deal with it. And part of this is because that there is some relatively low specificity, meaning that if your PSA is abnormally high, so above the 4 nanograms per milliliter, it doesn't necessarily mean that you have cancer. So you could have cancer, or you could have something benign like prostatitis, inflammation, chronic, or acute. That's not super helpful for someone waiting for their results. You might have cancer, you might not, but this is abnormal, we think. The second thing that is difficult is clinically significant cancer in patients with a PSA of less than 4 is present. So you think, my PSA is less than 4, wonderful. Unfortunately, not the case. So in the prostate cancer prevention trial back in the early 2000s, which included about 3,000 men, in 15% of the men with a normal PSA, less than 4, there was cancer detected. And in those 15%, there's another 15% which had clinically significant cancer, meaning that even with a normal PSA, that proportion of men had cancer that would affect their mortality and morbidity. So as good as we are at detecting cancer earlier, and as important as it is to have PSA as essentially non-invasive screening test, it still has its limitations. So this is where, you know, the hated systematic transrectal ultrasound guided biopsy comes in. Now, there's been historically different numbers of cores and biopsies, different types of techniques to try and optimize a better sampling of the gland. In our institution, we go with a 12-point systematic biopsy when we do the systematic biopsies. So for the men who have yet to experience this and the women that have yet to support them through it, essentially you go through the steps of bowel preparation, a little bit like a colonoscopy, terrible experience. You can go have prophylactic antibiotics. Usually in our institution, it's fluoroquinolone. So you have a 3-day oral oral regimen of ciprofloxacin. And in terms of institutional practice, it's variable as to whether you have sedation, topical local anesthetic during the procedure, or a regional block. And we'll kind of go through that step by step. This is the diagram. If you think of the top of the slide, That's the front of you. The bottom of the slide is the back of you. For reference, penis, scrotum, pubic bone, rectum, and that little pink thing's your prostate. So the transrectal probe and the needle biopsy, if nothing, this diagram serves to kind of illustrate how no one looks forward to having this procedure.
That's for sure.
Exactly. So as much as it sounds a bit terrible that it's a random biopsy, we make it sound better by saying systematic, there is a little bit of method to the madness. So this is a schematic of your prostate gland. This upper image is slicing you kind of by the side. This lower image is slicing you from the front. And this, as Brendan has referred to, is slicing the prostate like a loaf of bread. So the top is the seminal vesicles, so your head, base, mid, apex. Apex is towards your feet. So in terms of prostate anatomy, which I'm sure Shelley has discussed with you before, the pink portion is the peripheral zone. That encompasses about 70% of the gland volume. And then the yellow and the green portion, yellow is a transitional zone and the green is the central zone. So MRI, I think, the bigger brains here know, we essentially call it the central gland because it's somewhat difficult to distinguish on the MRI. And then this little blue portion is the anterior stroma, so it encompasses approximately less than 5% of the gland. Now, why is this relevant? Because you want to know statistically where you're going to get cancer. So even though it's a systematic and a random biopsy, you want to kind of get your best bang for your buck. So conveniently, cancer is 70% in the peripheral zone, so the pink, about 25% transitional zone, 5% central zone, and then kind of a less than 5% into the anterior stroma. So when we do the biopsies, we do try and kind of aim for those areas to maximize your detection. All right, so as I mentioned, historically, we've had 6-point biopsies, 10-point biopsies, 12-point biopsies, even saturation biopsies, which go upward of 30 cores, making this a less and less looked forward to procedure. However, currently our systematic biopsies are 12-point. So again, this is looking at your prostate gland en face, and then this is slicing it like a loaf of bread, base, mid, apex. So these little crochet needle looking things are representation of the needle. So we basically take your gland, split it into 3 levels, and we try and get mostly the peripheral zone, but a representative segment of it in these 12 points. Okay, so with the diagram and the overall description of the procedure, probably not something you're looking forward to, so we'll make it even worse by telling you the risks and complications of it. So intuitively, 3 major risks: bleeding, infection, and urinary related symptoms. So bleeding is exceedingly common. It makes sense. We're taking a needle, taking out some of your organ. So the types of bleeding that you can have are hematuria, so blood in the urine, hematospermia, blood in the sperm or ejaculate, and hematochezia, so blood per rectum. Those percentages are just an overall kind of percentage based on several studies published in this European Urology journal. Most of the bleeding is not severe, so there's less than 1% that is generally severe, warranting additional intervention. And should you need additional intervention, say for rectal bleeding, it's usually not too bad, involves a scope, maybe some cautery, etc. So not the end of the, not dire. Now, the important thing, and this is for note for the future perspective, is that bleeding seems to be relatively independent of the number of core biopsies when they go from about 6 to 12 biopsies. The bleeding exception is for hematospermia, which does increase with the number of biopsies. A little bit not intuitive, but seems to be less dependent on the number of cores. More relevant is the complication of infection. The reason for this is because infection can result in up to 6% rates of hospitalization. So the types of infection you can have include something relatively minor and intuitive like a urinary tract infection, UTI, or epididymitis. Structure is kind of in the vicinity. And then perhaps less intuitive are complications such as meningitis, osteomyelitis, and then of course sepsis, which is very consequential. Someone might kind of say, well, how do you get meningitis from a prostate biopsy, or osteomyelitis? So that's a bone infection. And really, it's just bacterial dissemination in the bloodstream, I think, that results in that potential risk. Now, again, some unfortunate things. So infection rates over populations and statistically have increased over time. So since we've started doing transrectal ultrasound-guided biopsies, infection rates have increased. The purported reason is because of antibiotic resistance, because we tend to use these fluoroquinolones, and if you've had exposure, you can get antibiotic resistance, and therefore for a subsequent biopsy, that antibiotic coverage might not be adequate for you anymore. Also, risk factors for infection include increased number of cores and repeat biopsy. So if I have to do more cores for you, that increases your risk. Somewhat intuitive. Every time a needle goes through per rectum into the prostate gland, you have a potential of introducing a pathogen. And of course, any repeat biopsies you've had, so men who've had a biopsy and need it again for active surveillance, for changes in your PSA, etc., unfortunately, you're also at a higher risk of infection. Probably a combination of just statistically having it again and a combination of this potential antibiotic resistance. The last thing we'll just glance on, urinary tract symptoms. So urinary retention, unable to pee, dysuria, discomfort during peeing is a relatively infrequent complication. It's self-limiting and can be treated with alpha blockers. Okay, so it's not all dire. Even though it's not a looked forward to procedure, there are lots of complications and risks, we try and optimize our technique because unfortunately, as good as MRI gets, you still need to have the biopsy to get the histopathology to get your surgery and your treatment. So it's still a necessary evil. So what do we optimize? Antibiotics, analgesia, and their approach. So antibiotic biopsy optimization is relatively straightforward. As I said, for our institution, we typically give fluoroquinolones, ciprofloxacin for 3 days, but it may or may not be sufficient. So things that scientists and doctors have tried to do are expanding the antibiotic regimen. So you include intravenous antibiotics, say the day of the procedure, or intramuscular antibiotics the day of the procedure, or increasing the amount of antibiotics that you give someone. Now again, intuitively, it sounds like it'll work for the time being, but you still have this problem with antibiotic resistance. The second thing we've tried, or the royal we, but is rectal swabbing for cultures and tailoring antibiotics. But it actually hasn't shown to show that much of a difference in your complication rate. And other techniques include changing the technical technique. So when you get a transrectal ultrasound guided biopsy, the needle just goes in. They've tried using antiseptic solution in between the biopsies, and unfortunately that also hasn't really shown a change in your risk of infection. So timely, the Alberta Health Services, under the guidance of the Infectious Disease Service, is actually currently investigating a new prophylaxis regimen to try and decrease this increasing rate of infection. Okay, so pain management, for those that have experienced it, it's probably tolerable but not looked forward to, and potentially quite uncomfortable, and for some patients quite intolerable procedure. And the general consensus is that you don't want a patient to go through this and have such a horrible experience that they'd not be willing to ever have it again, because unfortunately, though technology is advancing, the likelihood that you may need more than one biopsy still remains quite real. So my personal feeling is that to make something unpleasant as less unpleasant as possible is probably a good thing. So there's general evidence to support using some variety of analgesia. You can use pseudoanalgesia, so intravenous medications to make the patient feel more calm for pain management. You can use a periprostatic nerve block. Basically, that's using local anesthetic via needle, not unlike your dentist, but at a block either at the top or the bottom of the prostate. And you can use topical lidocaine jelly. My personal protocol is to use a blockade, so the injected lidocaine block, and also to use topical lidocaine. And anecdotally, the men seem to manage it pretty well. If you add sedation to it, it's kind of like a nap and you wake up and they're pretty happy. Okay, so last thing in trying to optimize technique is some docs have tried a transperineal technique. So instead of going via rectum, which intuitively is perhaps less clean. You go transperineally, so it's basically between the space of the scrotum and your rectum to percutaneously do a biopsy. It has increased in some popularity, but it's a relatively more cumbersome technique. It's a bit more time-consuming, a bit more public health money-consuming, and unfortunately, comparative studies actually fail to show a difference in complication rate. Okay, so segue into where we're going to get into MRI is the limitations of TRUS. As Shelley had mentioned, limitations are sampling of the gland. You really only get 1% of the gland, no matter how much you want to optimize the sampled area that you're doing. It has a low sensitivity, meaning that even if your TRUS biopsy is normal, it could be that we're missing the cancer. It also has, again, a high false negative rate, which alludes to, again, if you have a normal biopsy, you may need a subsequent repeat biopsy. And in one study, it's shown that on the first biopsy, your rate of cancer detection can be about 40%. On the second, it diminishes to 20%, and then on the third, it can diminish to 5 to 10%. And this is for systematic biopsies, okay? So if you're getting the same kind of biopsy over and over. So this sounds, again, quite dire, because you're not increasing your detection rate, you're increasing your infection likelihood. So again, what can we do to improve this? TRUS biopsy systematically, again, can misrepresent the grade of cancer, as Shelley also alluded to. So if you sample randomly and you catch cancer, you might not have caught the most clinically significant portion of the cancer within the prostate, which again also alludes to where Brendan showed you the images. If it's scattered in different areas and you happen to catch one portion of it, is it the most clinically relevant portion? And we, by traditional technique, tend to miss that anterior blue zone that we're looking at, just because it's the front of you. So when you use transrectal technique, you go from the back. Our core length is about 2 to 3 centimeters or so. If you have a large gland, if you're just not aiming towards the front of the gland, you're going to miss that anterior zone. And it's been accepted just because statistically you're somewhat less likely to have cancer there. And again, the morbidity and mortality that we've talked about. So really, what are the goals of biopsy? Like, what do you and I want to achieve if you have to come to me for a biopsy? So you want to minimize the need of you having a biopsy at all. You might have to get it, but let's get it as infrequently as we can. And if you're going to get it, let's maximize the yield. In that we want to detect any clinically significant cancer. We don't want to detect low Gleason cancer and make you worry indefinitely. We don't want to miss your high Gleason cancer and not have you sent towards treatment. So MRI targeted biopsy is you know, is no surprise by now. Is this the future? And I think we all think it is. Okay, so this again alludes to what Shelley and Brendan have mentioned. In many recent studies in the landmark precision trial, targeted biopsy, so using an MRI to guide transrectal prostate biopsy, has shown to be non-inferior, meaning it's better than our standard. And in the most recent, in January of 2018, in the Journal of Radiology, is shown to have an incremental benefit. So basically, it's better than what we're doing right now, and that's good. So let's just show a quick case to illustrate the point. This is a gentleman who's had 2 prior negative biopsies showing benign tissue and just some minimal in situ changes, no cancer. So he underwent an MRI because of the regional indications as we've discussed. And this is, oh boy, I don't read these MRIs, but I made the pictures as simple as I could. So this bright spot in the anterior zone is the DWI bright thing. So when I look for biopsy, these are the 2, money shots that I look for. I look for the bright spot, and then you look at T2 for the anatomy, and it is in that anterior zone. So it makes sense how it could have been missed on a systematic biopsy, while you're going for the peripheral zone, and you're often missing that anterior zone. Okay, so just schematically, the anterior zone, that blue, in the mid portion of the gland. So when you come to me, this is what the prostate looks. So this will be a video looking from the top of you to the toes of your prostate. So seminal vesicles is the beginning of this image right here, and then I'll just kind of let it roll through. So we're just cutting through the prostate gland like a loaf of bread, and you can kind of see that mandarin, tangerine size structure And when I do the biopsy, I cine through it to get a sense of the glandular shape, where the mid portion is, where we're anatomically looking. Sometimes you can find a correlative nodular finding, and then we make sure we kind of aim for that. Okay, and then these are just lots of ultrasound images of our core. So this is your prostate gland in cross-section like a loaf of bread. This white line is the needle track. So when we do the targets, right now our practice is to basically try and maximally saturate a target. In that if we're gonna do the biopsy for you with a target, we're gonna biopsy the crap out of it to find that cancer. Because we don't want you to have to get this more times than necessary. So this actually, we took 8 cores. So as you can see, the anterior portion of the gland is right there. So these are the needle tracks, anterior portion. We make sure we get to that area. And then this is the mid portion of the gland, if you'll believe me. So these are all our targeted biopsies here. So anterior mid gland. And then these are just a kind of a schematic representation of how I do this systematic biopsy. So right and left side, so base medial, base lateral, we kind of go the inner and outer to have a representation. Mid, medial, lateral, medial, lateral. Apex, so towards your feet. Medial, lateral. Same thing for the other side. Okay, and so just to refresh, this is that image when you cine the gland pre-biopsy. Okay, and this is the image of the gland post. So all these like little white lines that you'll see, these are the biopsy tracks, and then anterior zone mid there, where you hopefully see the white lines, is the biopsy tracks to kind of show that we've been through that area. And because of various technical factors, it is hard to prove that you're on the target, aside from showing all these things to kind of give some evidence, because we can't actually see the nodules on conventional ultrasound. So this case outcome for the patient, his PSA was 12, 2 prior biopsies, which had atypical cells and benign diagnosis, actually ended up having a Gleason 7 clinically significant cancer. Okay, so goals of MRI targeted biopsy, we'll round it up soon, is basically number 1, to minimize the need of biopsy, because no one wants it, it increases your risks and it's invasive. So you don't want it, we don't want to do it, we'll just do as much as necessary. In cases of diagnosed cancer, we want a tissue sample in the most clinically relevant region, which the MRI can help us with. In cases of no cancer detection, if I do a systematic biopsy or I do a targeted biopsy for you, I want to be able to tell you and your urologist and the radiologist that this is a true representation of the findings in your prostate. That if I don't find cancer here, there is nothing there to find. And we don't have to send you to subsequent biopsy. Maybe we'll have an MRI now and again to make sure there are no changes. So this is just a schematic of representation of ideally what I hope to achieve with a trust biopsy. You A, detect clinically significant cancer and the patient goes to treatment, or you B, detect no or low grade cancer and you could go to active surveillance in an ideal world non-invasively. So very quick to wrap up, targeted biopsy experience in Rockyview. So we've been doing targeted biopsies, recorded targeted biopsies from 2016 to date with about 106 patients. Just to recap some of the prior publications, in the Precision and Mass General trial, approximately 38 to 35% detection in targeted biopsy patients. In our 106 patients, there are about 105 lesions. There's a discordance in the number because, well, anyway, statistics, and sometimes there's more than one lesion in a patient. But if of the ones that are PIRAD 3 and 5 that's sent to biopsy, 44% of these have clinically significant cancer. Now, that's great, but of course you're thinking, what about the remainder of the percentage? And that's where, our future perspectives comes in. So we want targeted biopsy to be a closed loop service. So if you're a man that has a previously normal biopsy, your PSA is going up, your urologist is worried that you have cancer, we want you to be able to go to MRI. If you go to MRI and you find something or the radiologist finds something worrisome, we want you to be able to come to the biopsy, have a targeted biopsy that's representative of the findings. And in order to do that, I think you need to have a bit of a closed loop service. If I find high grade or clinically significant cancer, that answers your question, you can go to treatment. If I don't find it though, is that representative of what we found on the MRI? And it's always a learning curve. You know, the new machine changes our technology, changes the way things look. But in order to do that, I think we always need to keep a record, need to have a feedback, need to look back and talk to each other as to whether we're doing the right thing. And then the wave of the future, of course, is one day, you know, for you as men, our husbands, brothers, sons, fathers, you know, you want them to ultimately be able to, you know, get the PSA and then have an MRI. If you're going to have a biopsy, make it worthwhile. And ideally, you know, one day you might not need the biopsy beyond when you need to have treatment. That's it.
Let's look at the questions. We'll go through. We've got lots of time, so.
I want to ask you, when you're talking MRI target biopsy, you're talking fusion or you're talking open bore? Are completely two different procedures.
Yeah, so we're talking about all of the biopsies. We don't do any in-bore biopsies in the region, and all of the biopsies that would be done subsequent would be fusion biopsy.
Fusion with ultrasound.
Correct.
Okay, so that two-step process.
Two-step process, 2 different days, 2 different.
And who does actual biopsy? Radiologist or urologist?
So a core group of interventional radiologists in our group that specifically do procedures as their job. So basically they're imaging surgeons do these procedures. So they are radiologists, but they're interventional radiologists.
Okay, and current biopsies done so far, they were done by whom?
So that's no change from previous. So both the ultrasound systematic biopsies done previously in the region are also done by and large, I think, exclusively
By radiologists.
by radiologists.
It's different than in the States. In the States, most of the biopsies are done by urologists. In Canada, almost throughout Canada, all of the biopsies are done by radiologists. And I'm not sure why. In Europe, it's a little bit different as well. Like, I'm not sure exactly why, but in Canada, this procedure is done by radiologists.
I have 2 in US by radiologists.
By radiologists or urologists? Yeah.
One targeted biopsy by radiologist, open bore.
Right.
It depends.
It does depend, and I think the key is you want somebody who's done a lot of them. It doesn't matter if he's a urologist or a radiologist. You just want somebody that has experience. Yeah.
This is a little more basic, but a friend of mine he was in the U.S. Air Force. He had core biopsies of 15 done in the Veterans Hospital. That's 12 years ago. I'm just wondering, you've never done that many up in Canada?
So that alludes to sort of the historical, we can do that many. So we've done what's called saturation biopsies, and that can go upward of 30 biopsies.
Just below the speaker.
Oh, okay. So that can go upward of 30 biopsies. And when we do the targeted biopsies, we do the 12 systematic cores and cores on top of the targets. So, I mean, we've historically in literature, they've tried several different numbers, and it's all with hopes to have a better representation of the gland. Obviously, I think intuitively, the least number of cores you need in the most high yield areas is what you want, right? So that's what we're aiming for. But the 15, I think, is a bit of kind of institutional preference and a bit of, you know, just trying to get the maximum yield.
Are there different size cores on these biopsies?
Are they? Did they use 18 at the mass?
Yeah, same. Generally, yeah. It's actually a very good question. So anytime we're biopsying any gland, there's always sort of a trade-off in terms of the size of bore or size of caliber of the core that you're taking, rather, and potentially complications. And in most cases, the changes are minimal, and it's probably institution dependent. At the Mass General Hospital was, to your question, all the exclusively performed by urologists, and I believe they use 18 gauge. The only biopsies that came back to radiology actually were the challenging cases or the cases that didn't quite make sense with the MR, which we sort of did together or performed by
So what happens with the gland after it's undergone something like, say, 12 cores? How long does it take to grow back?
So that's actually a good question. In terms of the ability to see a tracted biopsy, if you image a patient with MRI, for example, shortly after biopsy within the next few weeks, you can see small foci of hemorrhage, and occasionally you can actually see the tract itself. But over time, we actually aim to perform MR imaging if the patient has had a biopsy 6 to 8 weeks after that, and beyond 6 to 8 weeks, at least by MRI, you lose basically any evidence that it happened. If you've had operative treatment, you've had the gold standard pathological look at your prostate.
Okay.
Because you've then had a pathologist go over the gland comprehensively, including a certain amount of slices, and had sort of an overall final diagnosis. Now that's not necessarily the case if the whole gland wasn't taken out. So there could be variability in the underlying original diagnosis. But further complicating the matter is that cancers don't stay the same over time. So the same mutations or several mutations that gave rise to cancer, that doesn't stop at that point, right? So a Gleason 7 that started as Gleason 7, if it metastasizes later or recurs later, does not necessarily need to be Gleason 7 as well. It can become higher grade.
And I guess the one other thing, if you've had a recurrence, potentially you had extracapsular extension and your margins of your tumor were not
Oh, I
opaque.
recognize that, yes,
Okay.
yes. I was just wondering about that original Gleason, because in our support group, we talked about what was your Gleason score, and follow that through, without perhaps a recognition that, well, that is what it was 7 years ago, and that's perhaps not how you would characterize the cancer as it exists today.
And actually, you make a very good point about that, because I still have one paper in my email that I still have to read from the head GU pathologist at Rockyview, and the Gleason scoring itself has changed over the last couple of years. So what might have been a Gleason 7 just a couple of years ago is not necessarily the same as a Gleason 7 today. So
where's the difference? Higher or lower?
I still gotta read the paper.
Yes, yes, it would be higher or lower.
Without getting into commercial considerations, what is the distinction between patients who have a prostate biopsy at Mayfair versus CFW at the Prostate Cancer Center? What is the streaming?
Oh, I'd love to answer that question, just because, so we're from Mayfair Diagnostics, and I do a lot of the CME for the family physicians who are there, and at this point in time, the very best magnet in the region is at the Rockyview, and you don't have to pay for it. And if you meet the guidelines that make MR useful, you will have an MR done. And so we've had lots and lots of discussions, as you can imagine, about private MR, and I'll premise that with, I don't believe in private medicine, even though my partnership has a private MR. So hopefully I won't get fired, but I believe that the work being done at the Rockyview is the best work being done, and I worry that some of the private magnets don't have the images that Brendan was showing, and don't have the radiologists that have the expertise to report the cases. And so I would say, if you're thinking about going private, talk to the urologist that you're working with, and they will if you meet the requirements, they will get you into the region, and that's the way I would suggest it.
Without dealing with the issue of MR, what patients come to Mayfair for biopsies? None. Okay.
No, all the transrectal systemic biopsies that are initial go to the Prostate Cancer Center.
That's why I
That's
was looking for where your involvement was.
So,
related to that, I have a subsidiary question, which you may or may not be able to answer. How familiar with, and what can you tell us about the Euronav that Dr. Swanee does at EFW?
Yeah, so The types of biopsies that are being done are all fusion biopsies. There are cognitive fusion biopsies and there's software fusion biopsies, and I've been involved with both. So for example, the way that I trained at the Massachusetts General Hospital was using specifically the Euronav system. And so right now in clinic at the Prostate Cancer Center, the Euronav system's been put in, and it supplants the cognitive fusion biopsies that we've been doing in hospital. There's been several trials that basically have shown that there's no substantial difference in the two in terms of rates of clinically significant cancer, nor the rates of detection of clinically insignificant cancer, nor the accuracy in terms of getting to the center of your core as targeted on MR. So two different types of fusion biopsy being performed in the city, basically with comparable results. Does that answer your question?
Sort of. I may talk to you a little bit later.
Sure.
I think the other point in that is Euronav, the Euronav platform is just one platform of the MR fusion software packages that are being marketed, and it's really important to make sure that those are rigorously evaluated. And what Brendan is talking about is that in the literature that comes out frequently, as we pointed out, they're being evaluated. And currently there isn't a leader in true MR fusion software. And I guess I would argue that the cognitive fusion currently in the region being done is probably better just because there's been more of it done. Would you?
I mean, there's no data outside of our cognitive fusion, so that's basically all I can say.
So just to have a bit of a pedestrian proceduralist take on Euronav cognitive, meaning my brain, versus software fusion. So in an ideal world, your software fusion would perfectly mesh your prostate on the MRI with the prostate on the ultrasound. But as you know, it's not a billiard ball, it's not hard and perfectly symmetric. So when you move, when you have an endorectal probe, when you have different planes of alignment, it changes all of those variables. And we've watched the software presentations on Euronav, and ideally it would be perfect, but alas, I think reality is different. And software fusion has been used by our interventionalists for other organs as well, livers, kidneys, etc. And the failing of it is that it really needs to be robust, because you can mesh a prostate on an MRI beautifully. You can mesh a prostate on an ultrasound beautifully, but you would need a transducer that can actually detect those in 3D live in a patient that's still moving and breathing and has pliability to their prostate gland. So ideally, if your prostate was a billiard ball that stayed still and we could mesh it perfectly to the trajectory, that would be beautiful. And you have your little Space Invaders picture of you shooting right through the target. And that's kind of what the software is trying to achieve. But the truth is in the results when they come out. So, and right now there's still, as Brendan said, there's still equipoise. I mean, everyone's trying to kind of get the best system, and if the Euronav or software fusion were the kind of silver bullet, I think it'd be more universal. I think we're all trying to figure out how to be more robust with the procedures and be more robust with the MRI, and that's why it's so important to keep track of these things, because you want to know where your gaps are.
I wonder, what are the guidelines for those on active surveillance who from time to time need the kind of MRI guided or targeted biopsy? What are the guidelines to get it, and who gets it, and who doesn't, and who decides about this?
Who gets MR and who gets biopsy?
MRI and then potentially biopsy. Who decides about this?
Yeah, so
what are the guidelines?
Yeah, so easy answer to that question, there are none. So as much as and as quickly as on the front line of diagnosis, evidence is evolving quite rapidly and actually with positive results. Active surveillance or monitoring in active surveillance is further back, I would say further in its infancy in terms of evidence basis and in terms of the body of knowledge. And so what you'll find is that that's basically on the cutting edge. And so when something's on the cutting edge, you will find that institutional practice varies wildly. And so in some centers of the US, you would get an annual MR.
Yes, but I'm talking here. Who decides who gets one and who doesn't? In our environment.
In our environment, that's a great question, and the urologists decide in conjunction with you. So if you are in active surveillance and you are loath to get a biopsy, I would say you would, what the urologists right now are saying is, we will substitute an MR for a random core biopsy, so year to year. And I think we've got probably 25 to 50 patients in that group now. So if you're active surveillance and you're like, I don't want another biopsy, there's no doubt that you'll get an MR. If your MR shows something, you'll probably get a targeted biopsy. So what Brendan says is absolutely true, and what we've tried to prove to you is things are changing really rapidly. And those of you who were there last time I was speaking, like, all of this is new, even just in the last year. So to keep up is hard for the radiologists. It's going to be hard for you guys as well. So it's going to be important for you to have really open communication with your urologists and say, you know, this is what I would like to do. But I think the goal of MR imaging is to take away the number of biopsies and to keep MR as the gold standard of active surveillance. So you have an MR every year. When something changes, that's when you move to biopsy. That's basically the goal.
I'm just
But
curious.
is that a goal, or is this achievable within a reasonable time, or is it a goal in the next 5-10 years?
Well, look at how far we've come
I know.
in 3 years, and I mean, I'm very biased, but I would say it's very achievable, because what we started by saying is random core biopsy is a 50-50 crapshoot. So why would why is that the standard of care? It is currently the standard of care, but things are moving really rapidly. And to your question, do we know the time frame? I don't think anyone knows the time frame, but in my mind, things have moved way more rapidly than I would have guessed. Brendan was very humble in the fact that there was no reason for the region to put in a 3 Tesla magnet at the Rockyview, except they believe that this prostate cancer work is important and is being done well. And so the way that they brought that in is with this recent literature. And so I think all of that is moving towards that goal of getting a better way to diagnose cancer than random core biopsy. Go ahead.
I'm just curious, like 30, 35 years ago, you just would have used CT scans to do all this work?
CT scans don't have the resolution to be able to differentiate malignant tissues from benign.
So it's never used?
No, and in fact, I'm
For prostate cancer.
after medical school, residency, and fellowship, I'm now 2 years into practice. And when I started medical school, none of this existed.
Okay, but that's a radiation load that we don't need, I guess, right?
For prostate cancer, CT is very good for many other cancers, liver cancer, like lung cancer, many other cancers, but prostate cancer is not seen with CT.
Okay. Such great questions.
Really?
And we are so fortunate to have the 3 of you to share your knowledge and your valuable time with us. We can't thank you enough for what you've shared with us tonight. So thank you for your time, your